Welcome to Cardiovascular Matters. Whether you are looking for answers for yourself or someone you love, we are here to give you the best information available. Each week, the founder of Cardiovascular Institute of the South, Dr. Craig Walker, and medical device sales veteran Terry Roberts discuss the causes, symptoms, treatment, and prevention of health-related issues stemming from cardiovascular disease. Now here's your hosts, Dr. Craig Walker and Terry Roberts.
Hello, everyone. Welcome back to Cardiovascular Matters. And again, this is educational purposes. We want to give the information to patients, family members, and loved ones about all topics in medicine. But our main interest here is cardiovascular disease. And there's a couple tests we want to talk about today that are not commonly used, and if you're interested in ways to prevent cardiovascular problems, these are two tests you may want to educate yourself in and find out if these have been done. Dr. Walker, let's talk about these.
Sure, Terry. Well, everything in medicine that I can think of, it is better to prevent than it is to treat once one has disease. And many people have recognized that, and so the whole industry of wellness has come about, wellness checks. And I think everybody understands diet and exercise and not smoking and drinking to moderation. All of these things are important in trying to maintain an ideal body weight. And they come in and they have blood tests because they want to see, do they have elevated lipids, or is there any evidence of kidney dysfunction, or what's happening with a uric acid level, which might cause gout, for instance, and may be associated with higher rates of cardiovascular disease? Is there any evidence of liver function abnormality? Getting those tests is common. It's what people typically do. But I think there are two really vital tests that are not performed frequently, and that I think that we really should be looking at more than historically has been done. So whereas I am certainly in favor of looking at lipids, and in particular knowing one's low density lipoprotein, I think those are very important, with many trials showing benefit from lowering LDL. There are two things, as I've mentioned, that are not routinely checked. One of those is lipoprotein A, and many people refer to that as Lp(a). But lipoprotein A, and the other would be C-reactive protein. Okay. Now, why do I think these are important? Or it has a lot to do with trials. There have been several trials looking at lipoprotein A, and these trials have shown that it independently is a very strong risk factor for going on to develop cardiovascular death and myocardial infarction. It's a strong risk factor. And what is so important about knowing Lp(a) or lipoprotein A is that statins in general do not lower it at all. It appears that atorvastatin might slightly lower it, but not substantially. And most statins actually raise lipoprotein A levels. They not only do not lower them, they raise it. And we have agents that have been shown to lower Lp(a) or lipoprotein A, including niacin. But niacin has a lot of side effects. It causes flushing in particular. It can sometimes result in some hepatic dysfunction, but flushing is the big side effect as we get into therapeutic doses. It has been shown to lower Lp(a). Now, in big trials looking at niacin in patients with hyperlipidemia, it did not show the massive decrease in cardiovascular events like statins had shown. However, I don't know if in those trials they isolated just those patients who had markedly elevated lipoprotein A. I don't know that.
Okay.
Now, one of the classes of medicines, however, that do really lower lipoprotein A substantially, or the injectable PCSK9 inhibitors. So we know that the antibodies to the PCSK9 protein do indeed lower lipoprotein A. And they lower it on the average about 30%. So that is very interesting. And I think it is something that should give us reason to measure these, because it may be what tips us over as to if we have to add something to a statin when treating high cholesterol, perhaps with the available agents that we have right now, perhaps that would tip my hand over to considering a PCSK9 inhibitor, because that's we do know that high Lp(a) levels or lipoprotein A levels are associated with higher risk events. Now, there are a whole host of drugs being studied now which independently lower lipoprotein A, but as of my last internet search, none of these are yet approved for general use. So we have to see what's happening. So by and large, the two medicines that I think play some role there would be the PCSK9 inhibitors, Repatha and Praluent, and inclisiran, or Leqvio is the other name for that. But it appears that that those indeed do lower it. That may also have something to do with the decrease in cardiovascular event rates that have been seen with certainly those first two, the antibody, the Praluent and the Repatha, alirocumab for Praluent and evolocumab for the Repatha. Those would be the generic names. Mm-hmm. Now, I think it is wise to look at that, because patients whose only lipid parameter that was elevated was lipoprotein A had higher event rates. And so I think this is going to be an area of greater focus in the future, and especially as new medications come out. I think you're going to hear more and more about this and looking for this. And I would urge anyone, when they're getting a wellness check, to say, yeah, I think it's great. I want to check my LDL, my HDL, maybe even measure particle size, because there's some data for that. But somewhere in here, I'd like to make sure there's a lipoprotein A value. And if elevated, consider that, and that could be important, particularly if one has a very, very strong family history of heart disease.
That's what I was going to ask you. Yeah, if you've got a family history, this is something you surely want to focus on.
You bet. We tend to trivialize genetics, but, my father was a farmer, and he often said, Craig, when you plant butter beans, you don't get roses. And there's a lot of that. That is very sage advice, because our genes determine so much. Obviously, environmental factors determine a lot, but our genes determine a lot. And it's a very important thing to keep those in mind in terms of treatment. Now, the other thing that I think is very important, and once again, something that we don't always check, is a C-reactive protein. This is an inflammatory marker. And C-reactive proteins have been shown to be associated with much higher risk of cardiovascular death and heart attacks. Much higher. Now, how do we lower C-reactive proteins? Well, once again, it's an area that there's a lot of research going on. There are all sorts of drugs being evaluated for this, but right now, there is a drug that's available to us. It's a very old drug. It's one that's been around for decades, but there's no pharmaceuticals speaking about it because it's generic, despite the fact that it is in all the guidelines of the American College of Cardiology and American Heart Association for treatment. And that drug is colchicine. Now, you may have heard about colchicine before, because colchicine has historically been one of the treatments that we use for gout. When someone comes in with an acute gouty attack, colchicine has been shown to help them relieve that gouty attack.
Right.
What we do in the case of a gouty attack, we're just treating one attack, and we give colchicine, and we keep increasing the dosage until the person actually starts to get very nauseated or maybe even has diarrhea, at which point the gout goes away. And we're using this to limit the inflammatory damage that the gout can do to our joints and to treat the pain that's associated there. Well, when we find an elevated C-reactive protein, there have been studies showing that lowering that with colchicine can indeed lower the risk of cardiovascular heart attacks and death. Now, the difference is we give it very differently. We give a 0.6 milligram in America. 0.6 milligrams is the lowest dose that's available. We take that once a day only. So we're not giving a bunch of the medicine. We're giving a little bit, but we're using it in a preventive fashion. Mm-hmm. And one of the other side effects I've seen in some of my patients who had elevated C-reactive proteins, that when I've started them on this, many of them tell me that it also helped their arthritis. Now, we have no study that I can cite on that, but I'm just telling you personal experience. As I speak to my patients, many of them tell me, doc, this really seemed to help. And I guess that makes sense if it's an anti-inflammatory and one does this. Now, albeit there are tremendous side effects when we give the big doses to treat the gout, as I've mentioned before, most of my patients have told me they've experienced no side effect at all. And so just to check that out, I tried it myself, not because I had an elevated C-reactive protein, because I wanted to be able to tell my patients what to experience. I don't do that with every drug, but I try to have a little bit of an idea, because I want to know what my patients go through. I don't want to tell somebody, ignore that if I experience it myself and I think, gee whiz, I've just told them the wrong thing, because we don't always learn all those side effects just from the package inserts. And so I took it once a night for a week, and I can tell you I felt nothing at all. And it didn't have anything adverse. So it gave me some pause, thinking, this might make some sense. Nor have I seen now any reports of bad outcomes. Now, this is not just a Craig Walker sort of an idea. This is now in guideline therapy recommendations by the American College of Cardiology and American Heart Association, that if one has an elevated C-reactive protein, that consideration should be given to using low-dose colchicine. I think interesting, but it's a tidbit that really, even in my own profession in cardiology, many cardiologists are not aware of, because there's simply no one promoting this at this time.
Right. And since it's a generic in those low doses, I would anticipate the cost would be very, very low.
Yeah, it's probably not as low as it should be. It should be dirt cheap. It's not as cheap as aspirin, of course. Right. But like for me, it probably had less side effects than an aspirin. And aspirin sometimes upsets my stomach if I take it. This was really fairly benign in my case. But I think that it's one of those things that's hidden. A lot of times, it's just, in today's world, there's such a wealth of knowledge coming out. It is tremendously difficult to keep up. I use AI to help me some with that. What's new in medicine, what's happening, interesting things that may have been passed up. And that's really an interesting area to look at, because we're seeing a doubling now of medical information in such a short period of time. It used to take years and years and years. And now we're down to weeks, that because there's just so much coming out. I mean, the information age is just that it can overwhelm us.
Right. Well, this is very interesting. I mean, for patients, especially, you're going in, you're getting blood work done for wellness checks, annual physicals, to ask about this lipoprotein, and also the C-reactive protein. Those two tests, are those a component of what you're getting? I mean, you certainly want to know that if your goal is to decrease, cardiovascular event rates. So great information.
Terry, lipoprotein A is inexpensive test. So is C-reactive protein.
Right.
Both have prognostic significance. Both have treatment options that should be considered. And I think in the future, these should become part of the standard battery. And I suspect we'll see that happen. It's just again, with the information overload coming out, we really have to create algorithms that allow us to address these things more effectively.
Outstanding. Well, again, these are meant as educational, and stay close to your healthcare care providers. Also, if you want to reach out to Dr. Walker's group, it's easy to do that at www.cardio.com. And you can certainly have these things checked out, because I know within Dr. Walker's group, this is just standard operating procedure for every patient that walks through the door. So they're not going to miss it. So I appreciate everybody listening to the podcast, whether you're watching us on YouTube or listening to us on Spotify or any of the other platforms. Be sure and like, subscribe, tell your friends about us. We appreciate that. Also, subscriptions are free. All you got to do is click the button, and then you'll know when new podcasts are presented. We probably do a couple a month, and we're going to continue to do so as we continue to build our content here. Also, if you have questions, you can hit us back via, especially on YouTube, you can just send in the comments section. I promise you I'll read them, I'll get back to you, and if there's topics you want to know about, if there's something that we can help with, we certainly will. Thanks again for tuning in to Cardiovascular Matters. I'm Terry Roberts. I'm here with Dr. Craig Walker. Thank you very much, Craig.
Thank you, Terry.
Thanks for listening, and please subscribe, like, and share this podcast with your friends and family. Join us next week for new topics and answers with Dr. Craig Walker and Terry Roberts on Cardiovascular Matters.